Welcome to Behavioral Health Champions, an exciting new opportunity to speak with California lawmakers and key stakeholders on the issue of behavioral health. We're going to talk about behavioral health policy, about issues related to stigma, and some of the challenges that we face here in the state of California. I'm Carmela Coyle, and I'm the President and CEO of the California Hospital Association, and with me is Jessica Cruz, the CEO of the National Alliance for Mental Illness California. Now, behavioral health affects all of us. 1 in 4 Californians will be touched in a single year by a behavioral health issue, and half of all of us will spend time at some point caring for someone dealing with behavioral health challenges. When we talk about behavioral health, we're talking about both mental illness and substance use disorders, two critically important challenges that face us not just in the state of California, but nationally. Joining us today is the governor's key advisor on behavioral health, Dr. Tom Insel. We are so grateful to have Tom's expertise and his advice as we in California begin to wrestle with some very important challenges and issues related to behavioral health. Thank you so much for joining us.
Thanks for having me.
So I'll get started. You have spent your entire career in the behavioral health space, most notably as the National Institute of Mental Health's director from 2002 to 2015, and now as the key advisor to the governor on behavioral health related issues. Can you tell us a little bit more about what motivates you? I mean, your entire career. So what was that driving factor that got you in, and what keeps you going?
Well, I started as a psychiatrist and trained here in San Francisco at Langley Porter, UCSF. Mm-hmm. And began on a research career in psychiatry, pretty quickly became frustrated. This was in the late 70s, and they just didn't have the tools we needed to be able to understand the disorders or to be able to do as much as we wanted to in many cases. So I moved and I became a neuroscientist. I spent actually most of my career in a field that later became called social neuroscience, and worked in a laboratory and did molecular, cellular kinds of neuroscience. Only much later came back when the tools had improved in about 2002 and got re-engaged on the public health questions of can we do better for people with mental illness? And I think for me all along, the question has been, how do we take the best science and apply it to get the best outcomes?
So let me ask, you've spent your entire career in this field. Talk to us a little bit about what you see as maybe the top challenge that we face, either here in California or nationally, as it relates to behavioral health.
Well, there are, not that many differences. I mean, California is struggling with some of the same issues that every state struggles with. I don't think anybody has kind of created the Camelot for mental health that we would all love to see, and that's true worldwide. There are lots of experiments. People have tried many things. But we're still in a world where we're dealing with mental health disorders at a late stage for the most part. I think of these as brain disorders, and part of what we understand about the brain is that the symptoms of brain illnesses are late, and that we know that in the case of Parkinson's disease or Alzheimer's disease, there have been changes for decades, sometimes multiple decades, before you see the first symptoms of the disorder. That's probably true for the developmental disorders like schizophrenia. But we get there for diagnosis late and for treatment even later. And the result is, just as in any other part of medicine, when we are late to the game, when we begin to intervene at a late stage, we don't get great outcomes. So I think the struggle we have across the country is understanding earlier stages, intervening earlier, beginning to think more rigorously about prevention. How do we move upstream and make sure that we're not always in this crisis mode of challenged by the most difficult and complicated cases? And that's often what we do. It's not to say we shouldn't pay attention to those, but we also need to eventually get to that point, like we've done in every other part of medicine, cardiovascular disease, cancer, diabetes, where we start to move upstream.
Yeah. We talk a lot in our coalition about the need to help people keep from falling into crisis, and that is all about prevention and early intervention. Talk a little bit about your views, the public. How do they feel about mental illness, substance use disorder? What is the public's perception of behavioral health?
I think there are two sides to that. The one side is that when you ask, as the Kaiser Family Foundation and the California Healthcare Foundation did recently in a poll, just around the time of the last election, so this is almost a year ago, they asked people across California, what is your greatest concern in terms of health? And the number one issue that they heard in that poll was access to behavioral health care. Pretty amazing, more than cost, more than access for cardiovascular care, diabetes, obesity, all that. This was the number one issue. Having said that, the other part of this answer is that almost everyone is struggling alone here. We all become what I call involuntary experts. We get into this because of a family member or ourselves, and we struggle assuming no one else has ever had to do this. And there is still such a difficult time in opening up and in learning from other experiences that, in spite of the fact that everybody says it's the number one concern, nobody wants to talk about it.
So could I ask, we're toiling in these fields alone.
Yep.
Talk about how these issues of behavioral health manifest in communities. What does this look like around us?
Most of all, they don't, right? So we know that over 50% of people are struggling in silence and out of care. That is not true for cancer, heart disease, diabetes, across the board. This area is an area which most of all is not in the care system. So the first thing you have to think about if you want to bend the curve for behavioral health is not waiting for people to show up to get care, because that's not going to get you there. It manifests itself when people do get into care, as we were saying, at a late stage. And so often what you see, the face of mental illness in California, is homelessness, incarceration, and suicide attempts with ER visits. That's what people see. And that is a small part of the way in which our whole population is challenged.
The tip of the iceberg, that piece that's sticking up above the water.
Right, and it's the most evident, but that also says that that's an area we do need to focus. We need to be able to do something about mental illness in the homeless community, mental illness for those people who are incarcerated. There is no other area of medicine where our response is to put people in jails and prisons instead of into healthcare.
And some would say that the outcome would be those people in the ERs, those people who are homeless and in jails. But what I hear you saying is that actually it's within our own four walls, within our homes. What do you think it's going to take to get people to reduce that stigma that means I'm somebody who has mental illnesses or behavioral health issues, is that I'm homeless or in jail or in the ERs, versus actually I'm struggling and I need to go and speak to somebody? What do you think a solution could be for those people who are struggling in silence?
Well, a lot of us are in that process now, and I think this kind of a conversation helps. You have to surface this, right? We have to be able to talk about it. We have to have the language for it. People have to have permission to know that it's okay. Just to give you some idea of how difficult this has been, it wasn't that long ago that employment forms would ask questions like, have you ever had cancer, heart disease, diabetes, or been treated for a mental illness? As if being treated for a mental illness was the problem, not the solution. So what I would suggest is the other piece that has to happen is people have to understand that just as in every other area of medicine, treatment works here. We have a lot to offer. In fact, I'd argue that we probably have more to offer than many other areas of medicine where people are eager to get care. We can do a lot. Now, people don't seem to be so hesitant to get care for their physical pain, but for psychic pain, there is just still this shame and blame that keeps people out of care. And honestly, we should be clear, we don't make it easy. Our own care system is not where it needs to be for people to get the kind of support that could actually help them.
And we're kind of on what you've termed this tipping point, right, in California, of increased focus on behavioral health. We have a governor who has put this as a priority. What do you think are some opportunities that are before us to help connect with a more comprehensive behavioral health system?
One word: leadership. What California needs is leadership. It needs to have a plan, a strategy that says this is an important part of healthcare. For us to be successful, we have to get beyond the brick and mortar of our clinics and our hospitals. We do need to build up those resources, but we also need to move upstream the way we've done in the rest of medicine. We need to bring in schools. We need to focus on the incarceration issues. We need to think about how to help people who are homeless and who are not in care. And make this something that California decides it will lead on. At this point, that has not happened. And I think we have a governor now who wants to make that part of his tenure, part of his legacy.
And I wonder if I can follow up on that. The three of us recently heard a presentation that talked about how we pay for behavioral health in the state of California. And that in and of itself, our history of how we pay for care, becomes a barrier to greater integration and coordination. Your thoughts on that?
With all due respect, I don't think it's the right question now. I think we should figure out what we want to do, and then we should figure out how to pay for it. You are quite right, Carmela. Every decision has been made based on the financing, and we do have lots of options for financing behavioral health care in California, more than almost any other state. The problem is you can't allow the financing to drive your care system. It almost always does at the end of the day, but you don't want to start there. You want to start by saying, this is the what. This is the North Star. This is what Camelot looks like. Then we'll talk about the how. Then we'll figure out what the financing operations ought to be to get us to that point. I don't feel we've done that yet. And that's, I think, the task right now, is to have a strategy that can drive how we do the financing.
And we would agree with you, that's the leadership opportunity. It feels as if perhaps we've been constrained by the past. Instead of thinking about Camelot, let me ask about Camelot.
Yeah.
In your mind, what could a better system look like 10 years from now?
Well, it's a system in which there's no wrong door, where access is certainly easy, where care is comprehensive and continuous, and there's a focus not only on having the structures and the access, but having high quality. One of the mistakes I think we've made over and over again, and parity is an example of this, is to assume that if we simply give people access to care, that we'll have accomplished everything we need to do here. It's important, that's an important step, but ensuring quality and improving quality in this space is every bit as important as providing access. So we need to focus on both of those things.
So talking about some next steps, you're very familiar with our Behavioral Health Action Coalition with 50 state organizations coming around this issue. We have and continue to stand with you to help and partner in any way to lift California to be its best in delivering behavioral health throughout in a comprehensive way. How can we as a coalition help you continue to do this work?
I think we ought to do this plan together. This is not a plan that the governor is going to figure out, or that Secretary Ghali is going to figure out, or that I'll figure out. We're certainly deeply involved now in beginning to outline what that might look like and identifying, like, where do we want the focus to be. I like to say, we could do anything, but we can't do everything. So we've got to understand what we really want to focus on. And that focus ought to be shaped by a whole range of stakeholders, individuals and families, people with lived experience, providers absolutely need to be at the table. People who are thinking about financing do need to be there, and we have to figure out what those tools are going to be to get there. So pretty quickly, I think we'll be at that stage of wanting to engage and start a broad discussion about, goodness, what is the opportunity here, and what should this look like? It is exciting. I think there's an awful lot we can do. This is a state with enormous resources, maybe unique resources, and being able to leverage those statewide, and being able to say, let's bring the University of California system in. Let's bring some of the extraordinary innovation from the counties. I've been on a tour this summer of several counties. Every county I go to, I come away thinking, wow, they are doing great stuff. The problem is their great stuff isn't being done anywhere else around them. So, using that experience and figuring out how to scale that, that's what's exciting. And we have lots of great stuff to point to in California. We just have to start to put it together in a way that serves everybody.
Let us ask one more question. You are a key advisor to the governor. Legislators, key policymakers looking to you for advice. And I'm certain you've had an opportunity in front of any number of audiences. What are the one or two messages that you really want Californians to hear about this challenge around behavioral health?
Well, I think the first is to be clear that we hear you, that this is a priority. And the second is that we need to communicate that we can do better. We really can do better. As I said, I think some counties are doing spectacular things, but we ought to be able to provide that for the state. You shouldn't have to be in the lucky county to get quality behavioral health care. It ought to be something that anybody in California can be confident they'll be able to receive.
We're all deserving. Yeah. So, if I may, Behavioral Health Champions is a production of the Behavioral Health Action Coalition. We are so grateful for your leadership, for your advice and counsel. I know we as a coalition stand ready to help in any way we can. We thank you, Dr. Tom Insel, for your time today and for your thoughts.
Thank you.
Thank you.
Thanks.